all the viewers who are watching this medical discussion organized by Lifecare Center. Today, our young professor, Rahul Jain, is going to speak first on seizures, and then the second topic he is going to take today is on depression. So over to you, Rahul Jain.
Good morning, everyone. Today we'll be discussing on depression and in brief seizures. I hope the presentation is clear and visible.
No.
Coming to depression first. Good morning, myself, Dr. Rahul Jain, and these lectures are happening under the guidance of Dr. Sharda Jain. So without much further ado, we'll go on to depression, and let's try to grasp and make it a very crisp session. So before I start a topic of depression, just a mention here that depression is such a big important disease that even WHO has in 2017 has taken it as just theme for that year. So the theme was depression, let's talk. So coming on to the definition. So there is no exact definition for the depression. It's just the common symptoms which are associated with depression associated in the definition. So we'll read the definition now, and then when we read the clinical features, it will be like a revision. So depression is a mental disorder presenting with low mood, low interest, and the patient won't feel any pleasure. So this is a very characteristic symptom. It is also called as anhedonia. So whenever we see anyone saying that when I used to go to movies before, I used to feel very good after the movie. But nowadays, when I even go to movie, I don't feel anything. So this type of explanation, that is loss of pleasure associated with previously pleasurable activities, is called as anhedonia, and it is very characteristic of depression, and it should give us hint that the person is depressed. Then one more thing is there, which it's not mentioned in the definition. It's called as emotional flattening. So nowadays it's a very common complaint and might be sometimes the first symptom of depression, that person says that I don't feel sad, I don't feel happy. So yes, this is also a marker of depression, emotional flattening. So the person stops feeling any emotions. Then there is a feeling of guilt, low self-worth. Then associated sleep, appetite, and psychomotor activities are associated with depression. So yes, this is the first one I want to highlight. When people say that today I'm feeling depressed, I feel it's a very wrong word to use. So we should know what is the difference between depression and sadness. So there are two different things. When we say someone is depressed, it is a mental disorder, and it requires pharmacological treatment for sure. Without medications, it's very hard for someone to come out of depression. But when we say today I'm feeling depressed, it is wrong terminology. It's that the thing is that the person might be feeling sad, but that person is not depressed. Sadness is just feeling of unhappiness, and it does not last very long. That's why we have a criteria of 2 weeks. 2 weeks is the criteria for calling someone depressed. So when all the symptoms, whatever we talk about under the depression, they last for more than 2 weeks, then only we say that some person is depressed. Otherwise, sadness is very common, and it is a part of daily emotions for everyone. So sadness is like one person will sad for 2 days, and then the mood will improve. So that is not depression. So we should differentiate what is depression and what is sadness, and should not label depressed to everyone, whoever we see sad. Then also depression is an important entity in terms that it will affect every part of the person's life. So it's not like that they will be depressed at home, but at work they will be happy. Or so when depression affects someone, it will affect their life as whole. So they will stop going to work, they will not do anything. But sadness is not like that. So the person might feel sad when he comes at specific situations, but when he goes to work, he might be acting normal. So again, that will help us differentiating between depression and sadness.
Correct.
So depression affects every part of the life. So social life, spiritual life, work life, personal life, every part of the life is affected by depression. So yes, the prevalence is very high in the society. It is estimated to be 12 to 17% of the whole population. So even actually in India, it is the most common psychiatric disorder. But in the whole world, it is the phobias which is the most common psychiatric disorder. But second number is by depression. But in India, it's the most common psychiatric disorder. And prevalence is very high, 12 to 17%. Imagine every 100 people we take, there's a possibility that 12 people have got depression in their life once at least. And then WHO estimates that 1 in 6 females and 1 in 8 males will be affected from depression at certain point in their life. So it is higher in females, the prevalence. Then coming to neurobiology, I'll keep it very simple. Basically, there are two types of neurotransmitters. There are excitatory neurotransmitter and there are inhibitory neurotransmitters. So when there is deficiency of excitatory neurotransmitter in the frontal part of the brain, we call it, it will cause depression. So my excitatory neurotransmitter is dopamine, norepinephrine, serotonin. So this holds very good, the serotonin, norepinephrine and dopamine hypothesis, because it has been seen that when a person has done suicide and if we take the CSF of that person, cerebrospinal fluid, by a lumbar puncture, there is low levels of 5-hydroxyindoleacetic acid, which is actually metabolite of all these three. So to start with, there was less serotonin, norepinephrine and dopamine in that person's brain. And when you did suicide, when you checked the markers later, we just found that even 5-HIA was low. So even before someone performs suicide and we think the person is at suicide risk, we can estimate this marker and we can say, okay, this person is at very high risk of suicide. His markers are very low, that this person is depressed. So this is one objective marker of suicide or severe depression, I will say. Then the same thing. The people with psychosis will have high dopamine, high norepinephrine in their brain. So this three neurotransmitters theory is very important and it holds good for most of the psychiatric disorders. So it's a serotonin, norepinephrine and dopamine depletion. The moment they come to normal, it will become depression. So I will like to highlight one more point here, that they might be low for us also on day-to-day basis. So suppose for us, today they are low and so we will feel sad. But then tomorrow the brain will recover and he'll start producing these neurotransmitters at normal levels, and then that's how we differentiate between sadness and depression. Sadness is very temporary and transient, while depression is a constant phenomenon. So these people don't become better unless you start them on drug therapy. So every depressed patient, we need to get psychiatric help. And yes, so then this one interesting neurobiological concept I wanted to include. This we say that there's something called as cognitive triad given by Aaron T. Beck. So what does this triad say is that it is just a vicious cycle. So suppose a person will feel, so first the negative views about the world. So the person will start feeling, okay, there is no future for me, and the world is not going to help me. Then world is really selfish and it's mean, and then later he'll think, okay, world is not there's nothing, no one's going to help me in the world, and then there is no future for me, and then he loses hope also. So selflessness, hopelessness, and there's no future, these ideas will keep propagating itself and person's thinking will keep going towards depression. So when are we doing any therapy for the patient, his mindset we have to change in perspective to these three. So we need to tell him that okay, it's not there are people who will come out to help you. Then it's not like that your future is doomed. You also have to help others, and others will help you. And then they overgeneralize everything. So suppose in a class of 100 people, a teacher is teaching something, and the teacher has taught really well, and then one student comes after the class and tells, "Sir, you have taught very bad. You're not taught nicely." So he overgeneralizes and thinks that yes, I am not taught nicely, but other 99 students are satisfied. So the negative views about oneself are mainly associated with overgeneralization. So then coming to the types of depression. So it's not just the one depression we know, that is major depressive disorder. There are multiple types of depression, and we should just have a brief idea about them. So first is major depressive disorder. Major depressive disorder is the main depression we know. That is a depression which lasts more than 2 weeks. Then coming to the second thing, dysthymia. Dysthymia is basically low mood, and these patients are not very severe, but they're chronically low mood patients. And we say when this low mood persists for more than 2 years, then only we call them dysthymic patients. So there is something called as double depression also. So what is double depression? So suppose someone is dysthymic and then he gets an episode of major depressive disorder during the course of dysthymia, then that is even more severe. So double depression. Then there is a postpartum depression that happens because of pregnancy hormones. So the incidence should be less than 4 weeks of delivery to call it postpartum depression.
Correct.
So, and there is something called as postpartum psychosis also. That is also less than 4 weeks of delivery. And in postpartum psychosis, separating the mother and child is very important. Because sometimes the mother in some hallucination during psychosis or some delusion can kill the baby. So separating the mother and child is very important. Then there is something called as seasonal affective disorders. So in some people, the depression is more during winters. So because they are not getting exposed to sunlight, so sunlight therapy for these patients will tell them to go in sun. So sunlight therapy is very important. Then bipolar depression, when people have depression and psychosis episodes again and again. And there's this one very interesting entity called as atypical depression. So what we know about depression is that these people won't eat, these people won't sleep, these people will have, will be withdrawn, but atypical depression is a different type of presentation. So what happens is atypical depression, these people will have weight gain, these people will keep sleeping the whole day, these people will eat a lot. So they have literally opposite type of clinical symptoms, but they are also depressed. So this atypical depression is one more entity. Then coming on to clinical features. So moreover, the clinical features are so I have put clinical features in the order of severity. So it basically starts as sleep disturbances and low mood. So then patient early morning awakening is very specific for these disorders. So patient will be sleeping normally, and then they'll start to wake up at 5 a.m. or 4 a.m. in the morning suddenly, and then they won't get sleep after that. Keeps on happening for every day. Then this sleep will keep getting accumulated, and then it goes on to low energy levels. Then they'll also suffer from anhedonia, that is loss of previously pleasurable activity. So to detect anhedonia in anyone, I need to ask history that previously they used to follow pleasure in something and now they are not getting pleasure. So then I know that it is anhedonia.
Correct.
It's not like that maybe some person never liked to go movies and today also he is not getting any pleasure. I don't call that person anhedonic. I need to find out that previously where he was feeling pleasure, and I need to ask targeted history to know that okay, now he's not liking the activity. Earlier he was liking it. So then I say that the patient is anhedonic. Then obviously the patient's energy levels will go down, and there'll be guilt, excessive guilt for no reason. Then patient's appetite. So normally in depression, people will stop eating, but if it's atypical depression, they will overeat. Then low psychomotor activity, and this is the most severe symptom, that is suicidal intent and ideation. So what is the difference between intent and ideation? Is intent means that patients just gives the intention of doing a suicide. If a patient says, I idealize the suicide, I think that I am not worth living anymore. But ideation means that he gives a date. He says that suicide is right, or he says that, okay, I am gonna do my suicide after 10 days. This is the time, this is the date, that's how I'm gonna do. So that is even more severe than suicidal intent. So yes, so these are the markers of depression, and in practice we should see them, because for any patient we need to screen them. We need to know that, okay, they're not going towards depression, and if we suspect anyone, then we should definitely take some interventions, get them psychiatric help. So then there's this thing called as paradoxical suicide. We have discussed this before also, but because it's a so interesting entity, I wanted to mention it again. So basically, when we start treatment for the patients of severe depression, there is chance of more suicide in the initial phase of starting treatment. So why it happens is, the reason behind it given was that to perform an activity, a person requires two things. He requires motive and he requires energy for everything in life. So, to perform suicide, the person requires at first low mood, and then he requires energy to perform that full action, because he has to do some things to perform the suicide ultimately. So, but when we give the treatment, it's the energy which improves first, and then it's the mood which improves. So if the energy improves first, so there's one point in the treatment when the patient will have good energy but still have low mood. So that time the chances of suicide gets high, and these are the few things because of which psychiatric treatment should only be started under psychiatric supervision, and we or anyone as a clinician other than psychiatrist should never start psychiatric treatment without psychiatrist supervision.
Yes, this is very, very important. This is very important.
Then coming on to the treatment, as we summarize the depression, so there is obviously pharmacological management, then there is cognitive behavioral therapy, and then there is electroconvulsive therapy. So what I want to highlight here is this pharmacological management will be that we'll discuss more, but cognitive behavioral therapy and electroconvulsive therapy, just what is important is that we have something called as cognitive distortions. So what happens that people start making this cognitive distortion based on the false feelings. So the false feelings, some people think that there is all or none phenomena. So they'll say like either good things happen to me or bad things happen to me. They happen in the clusters always. So it is like a cognitive distortion, and he has made this false assumption, and he will always, so suppose the day he will think that, okay, only bad things are going to happen to me because I have seen a black cat today. So he saw a black cat maybe today, and then he will keep thinking, okay, only the bad thing will happen today. So whatever the good things will happen on that day, he will ignore them, and he will think that, okay, it's only the bad things which are happening today, my life is very bad, and that will precipitate his sadness and depression. So when we do this therapy for the patient, first we identify what are the bad cognitive distortions the patient has, and then we address them and we clear them to the patient that world doesn't work like that. So this is a cognitive behavioral therapy, and it is very effective, and along with pharmacological management, this should be started simultaneously for the depression patients. So psychotherapy. Then electroconvulsive therapy are for patients which are suicidal and severe depression. So this is very interesting. So basically electroconvulsive therapy means, as the name says, convulsions. So convulsions or seizures, basically when we're talking about seizures, it is the overactivity of neurotransmitters. So when we say severe depression or suicidal patients, we know depression patient does not have the three transmitters, that is serotonin, norepinephrine, and dopamine. So if we induce a seizure in these patients, there is a possibility that the excitatory neurotransmitters become more, and that what actually happens, that in the patient who are suicidal having severe depression, electroconvulsive therapy is very useful. So we put them under anesthesia, we give them brief seizure, and we take them out. And it's been shown that electroconvulsive therapy is really helpful for these patients. Then coming on to the pharmacological management, we should know the pharmacological management because we might encounter, because since the prevalence of depression is very high, we might encounter any patient in our day-to-day practice with patients on these drugs, and we should know that what are the main side effects, so that during our treatment, if a patient complains of those side effects, we can tell them they are because of your antidepressants and not because of our treatment. So there are multiple drugs available. So first drug is reversible inhibitors of monoamine oxidase A. The drugs are monoamine. So coming on to this drug, reversible inhibitors of monoamine oxidase A, basic mechanism is, so if we see the first image, there is neurotransmitter coming out, and this neurotransmitter is getting used up and forming metabolites via MAO enzyme. So this MAO enzyme is there present in mitochondria. So when I inhibit this MAO enzyme, the neurotransmitter level rises. So basically, moclobamide will rise the neurotransmitter level, and the neurotransmitters are the only thing which are deficient in the case of depression, as we have discussed, the three neurotransmitters. Then we have tricyclic antidepressants, serotonin, noradrenaline reuptake inhibitors, and we have selective serotonin reuptake inhibitors. So as the name says, that they are inhibiting the reuptake of noradrenaline and serotonin. So again, in the second picture, if I see that serotonin is taken up back and then is getting metabolized and forming 5-hydroxyindolactic acid. So yes, the point of low 5-hydroxyindolactic acid in case of suicidal patients in the CSF comes here, that if they have low 5-HIAA, they'll have low serotonin. Then one more thing is that these enzymes are getting, these neurotransmitters are getting reuptake. So if I inhibit these reuptakes, then the level of these neurotransmitters will increase in synapse. So that's how these drugs work, that SSRI and SNRIs. So the common drugs with SSRI are most commonly prescribed. So we will see one or the other SSRIs in our practice. So sertraline and escitalopram, and they are not even used for depression. They are used for even multiple things. Even for migraine, they are given in migraine also. So we will see them in our regular practice. So the side effect of these drugs are weight gain and delayed ejaculation in males. So these are most commonly seen, delayed ejaculation. So if our patient complains of this after we started treatment, we know that the patient is an SSRI, we can tell the patient that this is because of your psychiatric medication. And in toxicology, we have studied there are something called as anticholinergic side effects. So all these antidepressants can cause anticholinergic side effects if taken in excess and even seizures. So we need to know these side effects, that anticholinergic side effects and seizures, that we have already discussed in our toxicology video, that what are the anticholinergic side effects or anticholinergic toxidrome we have studied there. Then we have atypical antidepressants also. They act in atypical way but on similar receptors. So they are very good drugs. They are the newest addition to antidepressant spectrum. We have bupropion, duloxetine, and venlafaxine. Duloxetine is very commonly used. Then that's it about depression. I hope it was very clear.
Very good, very good. बहुत ही बढ़िया. First. I think it was gave a real good insight of depression. I am impressed.